Thank you very much, Dr. Chandrasekhar sir, for making me a part of this course. So I think with Dr. Vijayaraghavan sir's talk and Chandrasekhar sir's talk, many of the concepts about general refraction would be very clear. I am going to talk now about refractive errors in children. So this graph, if you see, it shows you the refractive errors that are seen in the newborn child. This is hyperopia and this is towards myopia. So if you look at this graph carefully, you see that most of the children are born hyperopic. And then what happens, as they grow, the power gradually, whether it is hyperopic or myopic, there is a tendency to emmetropize. That is, as the eyeball grows, the eye becomes zero in its refractive error, tries to become. So we also need to know a little about the developmental aspects here. Premature infants are mostly born myopic with or without astigmatism, and full-term newborn infants are mostly hyperopic, very few of them are myopic, and also they have very high accommodative reserves. Coming to the preschool years, the axial length increases. Most of the growth in the axial length in children is in the first 2 years of age. So at birth, the axial length of a child is around 16.5 to 17 millimeters. So do you know what is the adult axial length on an average? Around 22 to 23. So from this 17 it becomes 23, and most of this growth occurs in the first 2 years of life. And school going age, from it grows very slowly from 3 to 13 years. It's only around 0.1 millimeters per year. So if it grows more than that, then there is a tendency to develop myopia, whereas if this growth is very less, then the children remain hyperopic. So why do we concentrate so much on the childhood refractive errors? Because this is one of the most common causes of visual impairment. In fact, it has been included in the National Program for Prevention of Blindness, and around 19 million children are visually impaired, and most of this is due to refractive errors. So uncorrected refractive errors, it's very easy to correct this and prevent amblyopia and permanent vision loss in children. And economic burden of this is very high, because you need to remember that in children it is a growing eye, and economic implications are quite huge considering the lifespan of these children. And myopia, in fact the higher pathological myopia has a lot of blinding complications, that is impaired quality of life and social, economic and educational consequences. Hence we need to concentrate a lot on these children. So there are various ways of testing the visual acuity in children. Less than 5 years you may not be able to do a Snellen's visual acuity. So if you see this child, child is matching the Cardiff acuity cards. So you have, this is based on the principle of vanishing optotypes. So you have certain optotypes here, which if the visual acuity decreases, the child will no longer be able to point. So that is the principle here, and based on that you can, it is usually done at 50 centimeters distance, and based on this you can calculate the visual acuity. It is very important to record visual acuity in all children, whether they are like 1 year of age, 2 to 3 years, 3 to 5 years. So we have different methods of testing the visual acuity in different age groups. So what are the challenges in children? Inability to maintain reliable visual acuity. So we have to look at different ways of estimation. So in very young children we do the cake decoration method, and even less than that we can do like Teller acuity, and now you saw the Cardiff acuity. And the 3 to 5 years we have the SG charts and the HOTV charts, matching principle, and then the Snellen's. And mostly you cannot expect them to cooperate, so you need to find a way to go around that, and there is a risk of visual deprivation and amblyopia, and there is association with strabismus. So what's required in pediatric refraction? Mostly if we may not be able to get a good subjective refraction, so we need to rely on retinoscopy. Retinoscopy is the most satisfactory and accurate method for objective determination of refraction, but it's an art, as you already heard from the previous speakers. So the retinoscopy is done, and if you are able to get a subjective, so this is a matching HOTV cards. You can see that the child is looking at the distance, and the child is pre-verbal, so the child doesn't know what it is but can point out to you, and you can get an estimate of the visual acuity. Coming to autorefraction. Autorefraction is basically used as a screening tool in children. We never prescribe based on the autorefraction. Autorefraction can be like this, or you can use a portable autorefraction. We usually use this in school screening purpose, just for screening, and we can never prescribe based on this because it gives a lot of false myopic readings and pseudomyopia even after cycloplegia. So what are the agents that we use for cycloplegia in children? They include atropine, cyclopentolate and tropicamide. Most children less than age of 3, atropine is the gold standard because to arrest accommodation, and in hyperopic esotropes of any age we use atropine, and also when we get very strong accommodation, variable readings, pseudomyopia, in all these cases we can use atropine. 1% ointment, it's a typo, sorry, it's 2 times daily for 3 days. And the onset of action is within 1 hour, but the duration is around 2 weeks. So we need to explain to the parents that the child is going to be a little photophobic. There are also some other side effects like fever. When we prescribe the atropine ointment, we need to explain to the parents that they used to use a very small amount, just a rice grain size. And if the child is having fever, then they can stop it and give us a call. And we usually don't prescribe if the child is having any seizure disorders, then we avoid atropine and cyclopentolate. So cyclopentolate, the onset of action is within 30 to 60 minutes and duration is 48 hours. So this is most commonly we use cyclopentolate for first time refraction in any child older than 3 years. We apply it 2 times at a gap of 20 minutes and then followed by 1 drop of tropicamide, and then we can do the refraction. Any older child repeat refractions, we can use tropicamide. So this is just a rough guideline for spectacle prescription in children, and so you can see that 0 to 1 years, only if the myopia is very high, around -5, hyperopia more than 6, with squint +3, astigmatism more than 3. So we don't usually we don't like to prescribe in very young children unless the refractive error is quite significant. Similarly, in 1 to 2 years, again you can see the values here. These are just rough guidelines. And anisometropia you need to prescribe earlier because you need to prevent amblyopia. So coming to refractive error and strabismus. So what do you do when the refractive errors are associated with strabismus? If there is hypermetropia along with esotropia, then it's good. So you prescribe full cycloplegic refraction. There is something called a high AC by A ratio. That means the near esotropia is more than the distance esotropia. So that happens because the accommodative convergence to accommodation ratio is little higher. So such children would benefit by the prescription of bifocal glasses. And myopia according to the visual needs, because myopia with esotropia, the prescription will definitely increase the esotropia, but always we need to prescribe for the refractive error. Even don't think about the squint, the vision has to improve first. So whatever it is, we need to prescribe even if it is a myopia with esotropia, and then tackle the esotropia later on. Coming to exotropia, exotropia with myopia is a good combination, because when you prescribe for the myopia, it is going to decrease the exotropia again. Hyperopia, again we need to correct it if the child has a risk of developing amblyopia. Nystagmus, I think I'll leave that. Okay, so I'm going to talk a little bit more about myopia because this is one of the most serious issues that we are facing right now. And the incidence of myopia worldwide, there is a lot of differences. If you see the Caucasian population, the incidence is quite less. In USA, Australia, the incidence of myopia is very low. Whereas if you see at China, India, it's more, China and Singapore population, it's more than 50% at 12 years. It's very high. Whereas in India, the population-based studies have shown around 7.5 to 10% around 12 years. So there is a lot of changes based upon the age, the ethnicity and the rural-urban differences. So this graph, if you see, is quite interesting, the global trends for the myopia between 2000 and 2050. So they project that by 2050, around 50% of the world population is going to be myopic, out of which 10% is going to be high myopic. High myopia being defined as anything more than -5 diopters. So you look at this graph, it's quite scary. This is where we are right now and this is where it's going to be. So again, this is driving home the same point. This is the prevalence at 2000. This is the prevalence that you would see at 2050. And you see the across all age groups, the incidence of myopia is going to increase like anything. So what if there is myopia? There is a lot of morbidity associated with it. It's associated with amblyopia, strabismus, other cognitive dysfunction, many other personality developments, poor school performance, very limited career opportunities, and also high myopia has a lot of retinal issues regarding lattice holes, macular degeneration, retinal detachments, cataracts, glaucoma. So all these incidents increases with high myopia. So what are the causes for myopia? One is genetic predisposition. If the parents are myopic, there is around some 10 to 20% chance of, if both the parents are myopic, for the child to have myopia. Prematurity, most of the children who are aggressive posterior ROP treated, laser treated eyes, they have a high incidence of developing myopia. And environmental factors, these are the ones that we can concentrate on. The more and more evidence points out that as the outdoor activity increases, especially exposure to sunlight, the dopamine increases in the retina, and as the dopamine increases, the myopia tendency is reduced. Ambient lighting, reading in very poor light, dark room, will increase the myopia. Prolonged near work, which all children are doing now, is increasing myopia. High pressure education systems, overuse of near electronic devices. So all these are modifiable factors. All these currently being performed in all households and schools, and we are not concentrating that much on this outdoor activity aspect, and that is why the global prevalence of myopia is increasing. So there are other diseases which are associated with myopia and hyperopia also. You can see a lot of syndromes here, namely Marfan-Stickler's night blindness, gyrate atrophy, congenital glaucoma, ROP, all these associated with myopia. On the other hand, Leber's congenital amaurosis, cornea plana, myotonic dystrophy are associated with hyperopia, and certain conditions like a limbal dermoid, ptosis. When any child with ptosis, you need to look for astigmatism. So high risk for progression in Indian, Asian eyes, female, urban population, parents wearing glasses. If the child is having near esophoria with full correction, it can progress, and if there are posterior pole changes, these are all red flags. So this is a thing developed by Singapore. They are more and more concentrating on including outdoor activities as a part of the school activity, reduce the school hours, increase the games period. There have been a lot of interventions to slow myopia. One of them is the COMET or a correction of myopia evaluation trial, where they studied the effect of using plus glasses for reducing the myopia, and they concluded that large lag of accommodation, if there is near esophoria and you prescribe progressive addition glasses and bifocals, it tends to improve the visual performance. But routinely it is not being followed. Another study was the CLAM study, which is the contact lens and the myopia progression study done in Singapore. Again, but this is not very commonly followed. One of the most promising interventions to slow the progression of myopia is the atropine for the treatment of study. Atom 1, Atom 2 studies and Atom 3 studies have come out. So Atom 1 used 1% atropine nightly over a period of 2 years, and they showed that it slowed myopic progression by 77% and reduced the axial length elongation in the cases as compared to controls. But with the 1% atropine drops, there were a lot of side effects, including glare, photophobia, and near vision problems. So they reduced it to 0.1, and now currently it is the 0.01 atropine which is being used. The studies have already, all the results have come out, and now it has recently been introduced in India by various companies, and it is freely available. And even in our clinic, we have started this. So the thing is, we can start in children who show a documented progression of around 0.5 diopters over 6 months. But the thing is, the parents need to understand that it's a long-term thing. They need to use the drops for at least 2 years. And we started by the age of 6 to 12, between the ages of 6 to 12, if they have progression. And the parents are willing to continue and come for follow-up every 4 months, and if they are ready to use this every day. So word about the national programs. So it's just Vision 2020, there is a high priority to correcting refractive errors, and it's in the category of childhood blindness. Various school screening programs are being followed, and the school screening is definitely very important for finding out these errors earlier on. A word about the frames. Whatever you prescribe, if the frames are not good, it's not going to really work. So we need to look at plastic frames, hypoallergic frames, the ones with which are easy to wear and which do not like create some irritation or something for the child. So unless the frames are comfortable, they are not going to use it. Thank you.